Thank you for that update, Ellen. I'll be turning it over to Ambassador Kolker shortly, but a few words about his very rich background. Jimmy Kolker retired in 2017 as Assistant Secretary for Global Health at the U.S. Department of Health and Human Services. And as such, he was the department's chief health diplomat, and he will draw on that experience in his upcoming talk. He also represented the U.S. at WHO meetings, the Global Fund to Fight AIDS, Tuberculosis, and Malaria. He was directly involved in the U.S. response to Ebola and Zika outbreaks and helped develop and lead the global health security agenda. Prior to that, he was with the State Department as a Foreign Service officer for 30 years. He was U.S. Ambassador to Uganda and to Burkina Faso. And prior to that, or in between, after his ambassadorship in Uganda, he was the Deputy Global AIDS Coordinator in the U.S. in the Office of U.S. Global AIDS, and helped implement the President's Emergency Plan for AIDS Relief, known as PEPFAR. He had Deputy Chief of Mission assignments at U.S. embassies in Denmark and Botswana, and earlier tours in the UK, Sweden, Zimbabwe, and Mozambique. Since retiring, Ambassador Kolker has joined the boards of Building Tomorrow, Mana Nutrition, the G4 Surgery Alliance, and the Firelight Foundation. He's a visiting fellow at Georgetown University's Center for Global Health Science and Security, and at the Center for Strategic and International Studies. He, in 2019, he received an honorary directorate from his alma mater, Carleton College. He holds a master's degree in public administration from Harvard's Kennedy School and a BA magna cum laude from Carleton. So with no further ado, I'm going to turn it over to Ambassador Kolker, who's going to speak on COVID and international public health diplomacy. Over to you, Ambassador Kolker.
Well, thanks very much, Mike, and thanks to you and Alan von Egman for getting me involved in the Foreign Service Retirees Association of Florida. And I'm just looking quickly at the list of participants. The community of global health diplomats has, can I go back on there? The community of global health diplomats is small, but I noticed several of them are here, and recognize Leslie Rowe, Catherine Hill Herndon, and as well as Mike, who have really will be able to add a lot of their own experiences to what I'm going to present. I also just want to shout out to Bill Pope, who I've known for many years in the Foreign Service, and my A100 classmate, Dennis Reese, who I'm sure I haven't seen in 30 years, but wonderful to reconnect with all of you. So all of you know that I am a dilettante at all of this, but I look forward to sharing my screen, talking for about a half hour, and then hearing your questions and comments. Global health has certainly been on everyone's agenda this year, and it's something that I've found to be a fascinating combination with skills that we have as diplomats and that we exercised in the Foreign Service. So let me try to share my screen and get on with the presentation. And large. Great. Will see on my screen it says enter search term, which I can't get rid of. I hope that that is not on everybody else's screen as well. So thank you very much though for looking at the table of contents. We'll talk about two cultures, about the history of global health, a little bit about the AIDS in Africa, about Ebola, about Zika, and then three different focus areas on COVID. And as I say, I hope there'll be plenty of time for questions and comments. First, just to sort of frame all of this, scientists solve problems. And if they see an anomaly or a pattern, they do research. And if the evidence is strong enough, they publish in a peer-reviewed publication. And they have solved the problem. Whereas diplomats are kind of just-in-time people. We put our priorities onto other people's agendas. And if you look at that, you need to know then who are these other people and what are their agendas? And is what the scientists have discovered actually a priority in that relationship or at that moment? And so the challenge for scientists is to package and communicate data and evidence in ways accessible to non-scientists. Most of us do not read peer-reviewed journals. The data rarely speaks for itself. And at the same time, we as diplomats and policy makers need to know how to understand and incorporate data and evidence in our persuasive arguments with our counterparts and in the decisions that we make in terms of policy. Almost every article you see in a scientific journal say, well, there's still, these are the unknowns, these are things we have to wait and see, more research needs to be done. Diplomats, as all of you know, need now or never decisions. We need just-in-time information, and the idea that there's uncertainty or that more research needs to be done actually is a paralyzing factor, not an ability to better interpret the data. So the challenges that we have will be, I'll try to exemplify in some of the experiences that I've had. First of all, there's a new paradigm. The historic paradigm of when we talk about global health is that medical professionals and people from developed countries are actually providing services for local populations to combat infectious diseases. And researchers from developed countries typically have applied for their NIH grants, developed a subject that's of interest to them, and then found a university or a researcher in a low and middle income country to help them carry out their own research. And even though vocabulary seems right now very 20th century, that this is foreign aid, that it's about donors, it's about recipient countries. And what we typically did was to provide a proof of concept or a pilot study or a center of excellence in those recipient countries. Mike, could you mute yourself? I think we're hearing your background noise. Thanks. There's a new paradigm, which I certainly at HHS discovered, which is that low and middle income countries have a critical mass of qualified nationals. Probably a third of Masters of Public Health students in the United States are international students, and that they want partnerships to be able to move their own systems into first world quality and access. And that I found that actually CDC has a comparative advantage over USAID contractors, because the question you get at HHS, and I'm sure Leslie and Catherine and others who have been in this world remember, the question is, how do you solve this problem in the United States? Who do we need to talk to figure out who's been through the same situation our nationals are facing in their own professional jobs? And research universities in low and middle income countries likewise have really matured into institutions which have very good researchers and are looking to be able to find funding and to find partners for their own research priorities, not the research priorities set by US institutions. At the same time, although probably 95% of the USAID health money traditionally has been for infectious diseases, virtually every country in the world now has a higher mortality rate and even a higher morbidity rate from non-communicable diseases or for chronic conditions such as HIV and AIDS, and what we may be coming up with in terms of COVID as well as a chronic condition. And so that changing disease burden also means that we have to look again at how we're building capacity in low and middle income countries, which services we can provide from as expats, and which ones need to be integrated into a national health system. And one thing WHO has done is the Global Fund is that there is now a national strategy for every disease and every condition. And those strategies mean that if we're to assist countries, we need to respect that national ownership. We have to figure out how we can add value to the strategies and activities that are already underway. And finally, preparing for outbreaks, epidemics, and bioterrorism, which had often been an afterthought or something that was sporadic in all countries, including our own, now is unquestionably needs to be central to health systems and to health response in every country. And this again makes us look at ourselves. How are we able to cooperate and improve the ability of countries around the world to respond? So The first example I'm going to give is about Ebola. I was ambassador to Uganda when President Bush in 2003 announced President's emergency plan for AIDS relief. And this was, although there were certainly political and economic factors involved, it was largely an ethical and moral issue. We had in the United States antiretroviral treatment, 3-drug combination that worked. It reduced the immune deficiency, therefore the opportunistic infections, and tens of thousands of people who were HIV positive who otherwise would have died were able to survive in the United States. But many suffered very severe side effects, and these were, the ART was administered under very strict medical supervision, a specialist MD, periodic viral load tests, which were quite expensive and needed a sophisticated lab to administer. The cost per patient was about $10,000 per year, clearly out of reach of most patients or even governments in developing countries. And we didn't have studies of long-term patient outcomes. There could well have been side effects, which these very strong drugs would have produced in HIV positive people, which we didn't know because the treatment was new. It was only introduced in the late 1990s. At the same time, here I was in Uganda. We had money suddenly to scale up our AIDS program significantly and for the first time include widespread treatment. But there were a lot of challenges. There were unknowns, and there was uncertainty about whether this would work for patients in isolated locations, not near a major medical center. The most common phenomenon of people who are HIV positive in Africa and started developing AIDS symptoms is that they stopped eating. So not only could they not cultivate their fields, but they were undernourished and had diet and nutrition challenges. There were almost no specialist doctors, let alone specialist nurses in HIV treatment. They were unfamiliar with the antiretroviral drugs or the kind of routines that were of taking multiple pills at precise times. We didn't know whether we would be able to monitor side effects and treatment failure. These people were not, at that time, didn't have cell phones, weren't able to communicate easily with practitioners. There's certainly no government except Botswana in 2003 that was already providing antiretroviral treatment to its own citizens, but yet there were more than 50,000 people in Uganda who were already enrolled in the 2 non-government or parastatal organizations, the AIDS Support Organization, the Joint Clinical Research Center, who were getting all care short of antiretroviral treatment. So all they needed was money to get the drugs, and they were certainly ready for treatment, and that was what was needed to save their lives. They were already getting everything else that they needed. And Alan Van Egmond, in asking me to talk today, said I should talk about my origin story. How did I suddenly, with no scientific background, no particular expertise or life experience in global health, become a global health diplomat? And I think early on in that PEPFAR program, I realized that the difference between what we've been doing at what USAID is very good at, which is to repeat proof of concept pilot programs and centers of excellence, and what CDC is very good at, which is surveillance and biomedical solutions guidance, working with ministries of health to improve the quality of their care. But neither of them had much experience with national scale up. How could we get HIV treatment to people who were not already accessing it kind of all at once with a huge campaign and effort? And clearly, as all of you know, this involves not just being good at public health or being good at clinical medicine, but the politics. How would you prioritize this treatment? How would you get people to provide it and accept it when there are trade-offs in terms of other things the medical system could be doing? The economics were a huge problem. These were very expensive drugs. We had to bring down the cost, and we had to make the delivery coordinated with Uganda's ability to deliver these services. Governance, who was in charge of this? What was the US role? What was the local government's role? What was the role of these NGOs who actually were providing most of the AIDS care in Uganda at the time? The sociology of this, as we know from COVID, public diplomacy was a huge part, and the ethics. So these are not areas that only USAID or CDC is involved with. Clearly, ambassadors and country teams were essential, and we had to engage with counterparts in all of those areas to be sure that what we were doing was going to be owned by Uganda and would be accepted and would be able to be implemented. We couldn't just come in and have a PEPFAR program. We needed to do it, figure out who our local partners were and what the respective roles were. And there's a real question in terms of global health. I think many of my ambassadorial colleagues at the time really asked the question, is this what we do? We don't have the expertise in this. We don't have experience. When there's a health challenge, we turn it over to USAID and they contract, they're good at moving money, and this is how it works. And what my experience was that PEPFAR showed that we can and must use diplomatic skills in order to advance these public health goals. And that although with the exception of a few people who are on this call, we were really very few fish in this pond of aid and health diplomacy. When we were called on to do something that was quite risky, did we want to take the risks of not knowing what the long-term consequences of this treatment were if we were giving tens of thousands of people in Uganda treatment that was unknown to them before, US government pushing this treatment, paying for it, recommending it, and something goes wrong, the risks to us in terms of our relations there, certainly the lives of the people who were affected, was something that we really did have to calculate. If this didn't work, the cost to the United States, both monetary, but especially in terms of reputation and partnerships, was great. Ebola was a much different kind of challenge. It was an emergency response. The WHO structure and response turned out to be entirely inadequate to the needs of Guinea, Liberia, and Sierra Leone. The WHO representation in those countries did not put public health first. They were very much enabling denial by the ministries of health and the governments of those countries. But the question then is, Guinea, Liberia, and Sierra Leone are not countries where the US has major security, economic, or even consular interests. Who owns this problem? What are US interests? And the Doctors Without Borders, ironically enough, were the people who kept insisting the only people who have the logistical ability to meet the need of establishing the treatment centers that are needed in these countries, which were being abandoned because of their inability to be secure, to achieve the medical PPE, personal protective equipment standards necessary. So only the US military can solve this problem, which was partly true. Probably they exaggerated the case. But the military had no interest whatsoever. This wasn't core to them. They were overextended in Iraq and Afghanistan. And why should they be delivering what they called tents to West Africa as part of the US defense posture? One of the conditions for us getting involved, President Obama did convince the military this was a national priority. We did realize that we needed to step up. Without US leadership, this wasn't going to be done. We got the British and French to cooperate with Sierra Leone and Guinea, respectively, though to a foreign service audience. I was the only person who pointed out in HHS the irony of saying we should rely on France to deal with Guinea, one of probably the tensest post-colonial relationship in African politics. But people jumped to conclusions that the French must be the right partner for Guinea, but we were the right partner for Liberia. And our responsibility there included setting up a treatment unit so that health workers would be motivated to provide the care in rural areas because they themselves would get first world quality treatment in a center set up and staffed by United States medical people. And the military did provide a field hospital, which had a dental unit, an obstetric unit, other things completely inappropriate to the Ebola response. But this was modified, and they did stay long enough to make some of those physical modifications. But the staffing was entirely the responsibility of the US Public Health Service, which is part of HHS. So here I was as the head of global affairs at HHS, needing to work with the embassy in Monrovia to answer just a huge number of practical questions. Who from the public health service could go? All of them had day jobs. There's 6,000 of them, but they're the core of the Indian Health Service and the US Prison Service. They were working in important jobs. The Ebola experts were already involved in Ebola. So getting them to volunteer for six week stints in West Africa was quite a challenge. And of course, they weren't licensed to practice medicine or prescribe drugs. We didn't have a protocol for what would be the standard of care at this supposedly US standard treatment facility, but which lacked lots of facilities US practitioners would have expected. These people were not trained as Ebola specialists. How was that training going to be provided? In the end, it was CDC using a military facility in Alabama that gave our public health people priority access, even though there were many domestic people waiting for that training. And then the practical ideas, which we all know in the Foreign Service, of deploying people overseas. Who is responsible for the security of these US government employees, for their housing, for their water, their transportation? How would they get just the basic facts of moving a cohort of about 70 people for 6 weeks to live in outside of Monrovia, Liberia? And then access to the facility. Who could, this was for health workers. Who was a health worker? Was the cleaner in the facility a health worker? We decided yes, person was exposed to Ebola patients. But what about the person who did the finances for the NGO in a office in the Capitol? Was that person a health worker? And what about the CNN employee a reporter who was with the cameras running, coming to the gates of our facilities saying, I'm worried that I have Ebola, can the US taxpayer supported facility treat me? And it turned out the Deb Malik and the embassy in Monrovia were fantastic in helping to address all these problems and solving most of them. We did have a platform at HHS to answer these questions. And so the second aspect of health diplomacy, the first is you need diplomats to scale up. The second is if you have an emergency response, you have to solve practical problems which diplomats and embassies know how to solve. A much different case, but the next epidemic was Zika. And of course, in 2016, Brazil thought it was doing everything right. And then President Dilma called President Obama on the 1st of February, 2016, and said, you know, we're Brazilians, we know how to do this. We've got everything solved, but just in case, would you mind sending your 12 best experts down to Brazil right away? Just be sure we got it right. And so 2 weeks later, I was leading the US's 12 best experts on Zika, from several from the National Institutes of Health, from CDC, from FDA, from HHS, to talk about some things, some issues we had, and that they weren't sharing samples. So we, for instance, couldn't get an assay for blood safety in the United States. There were a number of vaccine platforms for chikungunya and dengue we thought would work for Zika, but we weren't able to get the samples or the collaboration of the Brazilian institutions because the Ministry of Health was holding that up. And the CDC had a team ready to go to the cohort study to look at birth defects, which were the most troubling of the consequences of the Zika outbreak. But again, they couldn't get Ministry of Health permission in Brazil to actually send this team to do these things. So we had an agenda, but the real question was, how could the Brazilians, these technical people, cooperate on these technical questions and get political approval to do so? And it turns out that diplomats actually are pretty good at this too. And over 2 days, this team of our 12 best experts and myself, my counterpart being the Brazilian Minister of Health, ironically enough, although I was just an assistant secretary, negotiated a 14-point matrix of how Brazilian parastatals and US technical agencies would work together. A lead person was identified, or a lead agency for each. And this got the minister and I then, with great flourish and before some cameras, signed this MOU. And so we had political approval for the technical people to get on with it. We didn't have to be experts as diplomats on what they were doing, but we needed, in Brazil and in many other countries around the world, you've all experienced this, you simply need an umbrella document that says these people are authorized to work with these other people to advance a public health goal. And we as politicians need to step back a step and let them get on with it. And about 4 weeks later, the Brazilian government disintegrated. But luckily, this matrix stood the test of time. And as new governments came in, new ministers of health were able to continue the technical cooperation. So a third example of where diplomats were essential to achieve public health goals, and public health could help our diplomacy and bilateral relations with a complicated and very proud country like Brazil. Moving now to COVID. I want to start this because we haven't paid enough attention to the background of our relations with China, which was a major priority for HHS during the time I was there. And after SARS, the 2003 SARS outbreak, the Chinese established a CDC very consciously on the US CDC model. US CDC office in China was embedded within the Chinese CDC. This was about an hour from the embassy location. And we, when in 2013, when there was a bird flu outbreak H7N9, about 40 CDC experts surged to China, and with their Chinese counterparts, the direct surveillance brought this under control. It turned out not to be a pandemic. It didn't spread from China, that we averted what could have been a major disease outbreak in the world. We also worked together on Ebola in Liberia, on establishing the Africa Centers for Disease Control. And we concluded 3 bilateral agreements. And again, as in the Brazilian model, Chinese more so, technical people in China don't just of their own will decide to share information or collaborate with American government officials, but you have bilateral agreements which say these people are authorized to share this kind of information with these other people. And that we had really a wonderful relationship with that Chinese CDC, and we were training their epidemiologists. And up until the beginning of the Trump administration, we were not dependent on Chinese official statements or for the WHO for information about outbreaks. We were there with the Chinese CDC co-investigating the outbreaks and the health developments in China. But that changed starting before the Trump administration took over, and that the Benghazi fallout, and I really tried to drag my feet at HHS, and I'm pleased to say we didn't make the CDC move while I was still in office, but the writing was on the wall, and they eventually had to move to the embassy compound, so they were no longer had this campus water cooler contact with their Chinese counterparts. And then as part of the Trump administration's bilateral policy with China, there was strong pressure to reduce our footprint, as they said, in health cooperation. And the CDC staff, including locally employed staff, dropped from 47 to 14 by the time of the COVID outbreak. And the last CDC embedded person, who was the person responsible for this epidemiologist training, left the Chinese CDC campus on July 2019, which was fatally responsible in part for the poor cooperation between ourselves and China, poor communication when COVID broke out. And then again, to me, incredibly, when there was an outbreak in China and we drew down the embassy staff, part of the evacuation include all FDA and NIH staff, not CDC or the health attaché, but all FDA and NIH staff were evacuated from Beijing. And this meant that, for instance, as we were trying to get personal protective equipment from China through the Chinese Medical Products Authority, which is the sole agency able to export medical products from China, the US counterpart from the FDA, who was full-time liaison with that agency, was operating 12 hours away from Bethesda, Maryland, and didn't speak Chinese, separated from his local staff. So the whole attitude of how we dealt with China at the outbreak of the epidemic was, from my point of view, a kind of own goal. We unilaterally disarmed in our ability to deal with an outbreak in China. And all 3 of the enabling agreements expired after I left government. There was a binding health protocol that expired in 2017. Chinese were willing to extend it. We declined to enter negotiations to renew it. CDC cooperation agreement expired in 2019. And even more ironically, an emerging infectious diseases protocol was never implemented during COVID before it expired in June 2020, again, with no attempt on the US side to prolong it or renegotiate. We did have an interagency process in the US. As you know, the directorate at the White House was abolished in 2018, but there were 2 very good strategies developed by the White House, the National Biodefense Strategy and National Health Security Strategy. These called for in the event of an outbreak like Ebola or like the one that came with COVID, that a task force chaired by the Department of Health and Human Services would be established to coordinate the US government response. But again, as the people on this call know, and I mentioned at the time as we were trying to figure out who has responsibility for what within the government, the HHS has no mandate for economic or security work. And if there's really an outbreak, those are two absolutely essential components of what we need to talk about. And from my experience in HHS, I can affirm, and I think those who have been counterparts in state know well, that HHS has very little knowledge of how state or DOD or USAID works. And HHS can't instruct embassies. Here's a global outbreak, we're having a global response. And the leader of that has to go through 2 or 3 other channels in order to actually send a message to embassies that gives only the Secretary of State or implicitly the White House through the Secretary of State can instruct embassies on what to do. So the global response was handicapped. And indeed, even domestically, that task force lasted only a couple of weeks, and it was replaced by a group led by Vice President Pence. And this model has actually been strengthened and continued in the Biden administration. They did reestablish the director for global health security within the White House. But the COVID response has been through a very powerful White House coordinator who convened interagency meetings, not through devolving power to departments and agencies, as it would have been an alternative model for how the White House might have handled this epidemic. I'll talk a little bit about state because this is where most of the audience knows what's going on. And as we have a former director of OES IHB on the call, that is the go-to office within state for global health questions. The Office of Global Health Diplomacy, which Leslie Rowe headed when it was separate from the PEPFAR office, although still headed nominally by the AIDS ambassador, that office now has been fully absorbed by the Office of the AIDS Coordinator. And I have to say has not been involved as directly in the global health response. It's much more been talking to embassies about the AIDS program and trying to get diplomatic support for AIDS goals during the last 3 or 4 years. And we have, of course, a very capable cadre of ESTH officers, but I put the H in parentheses in a little, in small letters, because almost all of those officers have had expertise and background in environment science and technology, almost none of them in health. And health has been an orphan at almost every embassy where I've ever served or with which I'm acquainted from the state side. It's been something USAID took the lead. The country team member speaking for health was the AIDER CDC director. And the state's internal capacity and expertise was highly limited and certainly not spread out widely among embassies. The Science Advisor's Office at State has rarely engaged in health matters. Geographic bureaus all have regional affairs offices, which all have somebody designated to be responsible for health, but those people are also very junior, often don't engage, rarely a full-time job. And when there is a crisis or outbreak, as we all know, state sets up a task force and then brings in people from all over to depending on what they see as their needs. But this ad hoc response means that we don't have the inherent capacity to actually take government leadership when on global health issues in peacetime, when there's not an outbreak, when we're not having a task force and it's part of an emergency response. So this administration did name Gail Smith the coordinator for global COVID response and health security. That office is very thinly staffed. They're using some people from OES IHB, but the question is what's needed. And from my point of view, that office is the beginning of, but not the answer to, what's needed from state, which is interagency leadership, ability to motivate senior people to attend these interagency meetings, which the White House is scheduling several times a week. There, especially the offices, all the first bullets there need 7th floor visibility and access. These are not mainstream offices. They don't often have a voice at the Secretary of Staff meetings, and influence with the geographic bureaus. Again, it's hard to get on the agendas of the geographic bureaus with the way that health is staffed within the Department of State. And so I talked briefly to Gail Smith, and her main complaint was, how do we get the attention of the assistant secretaries? They want to do something, but they've all come to me as consumers of our services, of people, we need vaccines in country X. Can you get us something? Not that they have a leadership role or that our embassies have a leadership role in dealing with a global health crisis. And finally, this whole question of interaction with embassies, the staff dealing with global health has not included enough foreign service officers, has not included enough people with field experience. And the question of how do embassies work, how can we use the resources that we know we have in embassies is a key question. Okay, very quickly, I'm going to go through this. I know we're very close to time. I'm sorry to take up so much time. This slide is mostly, it's too complicated, but we've spent billions of dollars developing these vaccines. And as we expected, 3 of them have been approved. AstraZeneca also seems to be effective, but 3 of the vaccines in which we invested and made 2 of the market commitments in advance actually aren't yet part of the global inventory. Novavax probably will be, but Sanofi and Merck actually abandoned their pursuit. I'll close for a minute with the vaccine, the kind of vaccine diplomacy. There needs to be, but is not, a global vaccine development and distribution agency. World Health Organization has, as Mike Burstein well knows because he worked there, has a limited role, limited budget. They do norms and technical assistance, not care. The Access to COVID Tools Accelerator, ACT Accelerator, was set up. Vaccine arm is COVAX. It's coordinated by the World Health Organization, Gavi, Global Vaccine Alliance, and CEPI, the Coalition for Epidemic Preparedness Innovation, which develops vaccines. And they do have a significant budget, billions of dollars pledged. Gavi, including or able to draw on the $4 billion that the US already pledged to Gavi in our regular budget. But what was missing as this was all being developed is that the US is the historic guarantor of this rules-based and science-based order. We account for 50% of public and an equal amount of private biomedical research funding in the world. This just isn't going to happen without the US government and private sector being at the table. And if rules are weak, Russia and China and non-technical companies and pirates are going to fill that gap. They have commercial deals already, as I'll point out, with places where they're doing human trials of their own vaccines. And the World Trade Organization work on patent protection and compulsory licensing is still a key factor which hasn't been resolved. The Biden administration switch on the idea of intellectual property protection for these vaccines has not actually resulted in a WTO decision on how that would play out. Just very quickly, a list of countries that already have deals with China or Russia to obtain vaccines. You can see some very important players, Brazil, Argentina, Indonesia, Pakistan, countries with huge populations and very significant needs. Here's the worldwide timetable. It will take 24 months to vaccinate the world. We will need 18 billion doses. That manufacturing, we're actually on schedule for this timetable, but it does mean that it's just a very, very long time. And we probably will have 18 billion doses for the rest of the world by mid or late 2022. But of course, in the meantime, Delta variant has meant that the need for that is now immediate, that we need to stop new infections as quickly as we can. And we just have never, we've always realized that we don't have the timetable to do that as quickly as we should. And the challenges that I've listed, the availability of glass vials, of safe syringes, of cold chain, of who's going to implement this, who's at the last mile. The cost of the vaccine is about 1/5 the total cost of actually running a vaccination program. Liability, intellectual property issues have been addressed, but they're hardly resolved. Vaccine nationalism has clearly come into play. There is not a free market in vaccines right now. Everything is by a government contract with the vaccine manufacturer. And we still don't know the duration of protection. The question of redundancy, over-ordering boosters is one that I'm sure all of us are considering, both as individuals and as national policy. this is very quickly where we are in terms of, as of last month, the percentage of people vaccinated. As you can see, Africa is at 5%. 5% of Africans. The blue is the doubled, who've been fully vaccinated, double dose or single dose of J&J. The purple is those who have been partially vaccinated. Europe, especially, as you see, the chart ends at 60%, so these bars aren't all that impressive. But Europe is by now actually over 50%. US is probably over 50%. South America and Asia are making progress, but the inequity of vaccinations not reaching poor countries is evident. That's the end of my proposal. I will stop sharing, and I'm sorry I haven't left more time for your questions and comments, but eager to hear what your reactions are and add to your expertise.
Okay, thank you very much, Ambassador Kolker. This was very, very illuminating. And obviously, I think many of us would have interest in having you speak longer, but in the interest of time, why don't we move ahead? I'm going to take advantage of the moderator and just make a few brief comments about my involvement in Liberia in 2015 at the tail end of the Ebola outbreak. And that's when I first met Ambassador Kolker and kept in touch with him since. As an American diplomat, and just as an American, I just have to comment that I felt a great deal of pride in my being an American and a foreign service officer by working at the WHO office in Monrovia, which expanded from about 20 people to about 175 people. And I believe I was the only American in that office for the 3 months that I was there. And we had visits by the new regional director for WHO in Africa, Dr. Moiti, who stopped by the office on our way back home going back to Brazzaville, where she was the regional director. And she commented on the incredible role of the United States government, thanked President Obama, thanked Ambassador Malik, and just said that, without the US involvement, that the response in Liberia would have failed. So, wow, talk about getting an attaboy moment for myself, whatever small role I was playing. And the major donors that directed money to Liberia via and through WHO, USAID was an enormous donor, Department of Commerce, a few other NGOs, and then followed by the World Bank. So I was administering all those grants. At that time, they were going down because Ebola was pretty much done, although it did pop up again while I was there. And I was administering grants totaling about $7.5 million, making sure that the reporting was done properly. So I really, WHO stepped up to the plate, and they played a non-traditional role because they really weren't implementers, they were advisors, but they had a key role in steering the money to where it belonged. And the country director was the co-chair of the Ministry of Health's weekly meeting that was convened in a huge round table or oval table where Doctors Without Borders were there at the table, the European community. So it was an incredible effort. And I really think that, as you commented about the role of France in Guinea, the same thing, the role of Great Britain in Sierra Leone was also considerable. So it kind of like reverted to colonial oversight, even though the US was never colonized, so to speak, Liberia. We were the historical partner. So I just wanted to mention that. And I'm going to go to questions here, and I'm going to ask, no open answered?
Yeah, let's go ahead with that one because it's an important one. This is
Frank,
ongoing.
Do you want to ask the question directly? Frank Young?
Sure, Mike. Yeah, can you hear me?
Yeah,
Yes.
we can hear you.
Great. Thank you, Ambassador Kolker, very much. And I think you probably touched on my question when you mentioned Gail Smith, the former USAID administrator, now being a coordinator for sort of global COVID vaccination contributions. But I'm wondering, and as you were talking about it, I was wondering if you could say a little bit more about how effective she is in her role and how effective her unit is in their role in persuading the not just the U.S. government, but the private sector to try and make vaccines more available, particularly in Africa, where Gail, I know, has a very strong interest and a strong background. My sense is that we're slipping off the issue by saying we can do both and just sort of letting it rest there. But I'm not convinced that answer is really an effective answer to an effort where I think we're falling way short. Can you comment?
Sure, I agree with you that we're falling short. And yes, we have to do both. We certainly can't neglect the outbreak in the United States. But my argument would be that in order to bring that under control, we have to do much more globally, much more ambitiously and quickly to help bring the outbreaks in other countries much better under control and spread, especially vaccines, but also treatments and oxygen and other things that are our more ethical responsibility to make available to people around the world. And I think Yael Smith is fighting the good fight. She absolutely understands this and is doing well, but it's part of the dysfunction of the US government that the vaccines that are actually donated, we're donating because we are under contract through HHS, mostly through this warp speed office that still exists within HHS with the private sector manufacturers. And so there are interagency meetings which agonize for hours and weeks over from which batch those donations should come and to which countries they should go. And then even though they're almost all, the vast majority are going through COVAX, we actually are requiring bilateral agreements and needing to take bilateral credit for getting those donations there. I'm sure you've all seen on our friends on Facebook, US ambassadors at the airports welcoming these donations with WHO, with sometimes representatives of the manufacturers. But the US, we have not established a regular system. Everything is a one-off, and each of them depends on a separate public-private cooperation. We certainly have encouraged manufacturers, the private sector, to provide manufacturing facilities. For instance, in South Africa, I think there may be some on the way in West Africa and in Rwanda. There are in Asia as well. So on the manufacturing side, we're doing more, but that of course is a medium or long range solution, not what's going to solve our problem this year in this country and around the world. I hope that was part of your question. We just don't get it right. The USAID people, by the way, Jeremy Conadike, who's the coordinator, was a fantastic hero and brilliant administrator during the Ebola outbreak. And it's to have him there, Beth Tritter, who's his deputy for partnerships and is trying to work with civil society and with the private sector, is also terrific. So the right people are in place. The question is the system doesn't work, and these decisions are being slow walked by the White House because they don't want to endanger any domestic equities.
Yeah, thank you very much.
Okay, thank you, Ambassador, and thank you, Frank, for your question. Catherine Hill Herndon, are you back? Can you ask your question? Aha, she's not there. All right, well, let me just ask her question because she said she was going to be out for a few minutes. The question is, what role is DOD playing that Catherine found when she wrote an article for the U.S. Army War College on the Ebola response, that DOD itself lacked internal coordination and reporting, making it even harder for other agencies to figure out what they were up to and to work effectively with them? Any comments, Ambassador?
Well, my experience is the same as hers, and Catherine, of course, was head of OESIB, and in that role played a role of trying to get all the US government actors to act in concert on a number of occasions, and it isn't easy. I think a great example just historically that puts this in perspective is that many of you will remember that in 2008, the Russians invaded the Republic of Georgia, and President Bush promised $1 billion to Georgia to help them fight back or to be better prepared. 300 million of that went to establish a state-of-the-art Public Health Institute in Tbilisi. And so this, however, this was part of our security assistance. And this was, decision was made without the involvement of the Georgian Ministry of Health, without the involvement of the US CDC, the people who were actually going to have to be cooperating in this. And so the Lugar Center, I visited there, it's a terrific operation. But Georgia would have been 99th on our list of top 100 priorities for National Public Health Institute. Their disease burden was not our priority, even DOD's priorities. This was done for security reasons, for other purposes with DOD. And about half the money going to global health security is in the defense budget. Some of it does a very good job, but it is for purposes for which it's being appropriated to DOD, troop protection, troop health, and also dealing with unexpected outbreaks in places we might have to deploy. Those are much different from what the global health priorities would be. And so I agree, there's simply no telephone number for DOD on health, on global health. There are dozens of offices and they all have money, they all have good purposes, their labs are excellent, but these are in a way solving the last war or the war before last, not the one that we're facing now on COVID or that we're likely to face in outbreaks in the future. The bioterrorism part of this is very important, but we need the same public health capacity to identify the pathogen and figure out what to do with it medically before we can even involve the security or law enforcement people that need to then address bioterrorism.
Okay, thank you. Another question has come up from Leslie Rowe. Leslie, would you like to ask your question?
Yes, Jimmy, thanks so much for this presentation. It's wonderful to see you again. And I'm just wondering, as you know, it really is all about the commitment of the leadership and the engagement, particularly at the State Department. I'm wondering if you're seeing a lot of engagement and commitment from the Secretary of State and other leaders in pushing our leadership globally on solving the COVID pandemic.
The short answer is yes, and I give Gail some credit for that, but I think Tony Blinken himself, just because of the weight of the epidemic, but also probably his own background and experience, has weighed in. He's certainly been at these interagency meetings, which, as you remember, I don't think that John Kerry participated in many on health topics. There was recently a joint letter by the Secretary of State and Secretary of Health and Human Services on how U.S. leadership on vaccines and on global response was important. The summit in connection with the UN General Assembly, although it took a long time in coming, and it's still a little bit vague in terms of outcomes or expectations, is clearly an example of how we are using diplomacy in a different way in the COVID outbreak than we did in previous outbreaks. And I think Secretary Blinken and team at State deserve some credit for that. But the interagency process is working in its own way. The White House is just taking a very, very strong leadership role, which I think State rightly should have more of, HHS should have more of, USAID certainly can be more autonomous in what it's doing. But the right teams are in place and the right people are leading them.
Okay, thank you. There does not seem to be any new questions either in the Q&A or the chat. So I'm going to ask you one. You were commenting, one of your slides had, capital E, capital S, capital T, and a small h on the role of the, the science officers among the FSO cadre. So in that regard, we all know, anybody that follows the news, the devastation of Cat 4 hurricanes on the coast of the Gulf Coast, Louisiana, Mississippi, Alabama, Texas, and a little bit of the Florida Panhandle, as well as elsewhere in the world with these cyclones that hit in the Far East, and the belief with a lot of, presumably scientific evidence that climate change is behind the frequency, the strength, and the damage being caused by these natural storms, not to mention earthquakes, not that they're increasing, but nonetheless, I'm wondering if you could comment on a global level, the relationship between health and environment, health and climate change, and how well or not well the US is looking into the future. You were talking about not wanting to fight the last war, but obviously looking into the future, these things are not going to go away. They're going to get worse. How well is the US prepared to deal with this on a global level?
Sure. Well, all of the actual outbreaks I referred to, probably including AIDS, are zoonotic. They originated first in animals and then became infectious in humans, but after they'd been in animals for a very long time. And that is, so the One Health, the zoonotic origins are directly affected by climate, habitat of rainforests, of people living closer to the places that hacking down fields and forests for their own agricultural use, children playing in areas where they might not have played before, such as the origin of Ebola from a bat and apparently a youngster who was affected. The issues surely also of how quickly things spread. We're living in a society in which urbanization and our transportation and so on revolutions mean that the whole environment for spreading a zoonotic infection is greatly increased. So these are related problems. There are many aspects of it, including US leadership, including the need for billions of dollars, including not just responding to things when they happen, but looking at ways not just to mitigate, but to try to deter or prevent something that we know is a threat from becoming a global threat or being as severe as it might be if we weren't taking preliminary measures to limit its impact. So there are lots of parallels. I think it would be, and part of the global health security agenda is this One Health concept of how are we working. USAID has some real expertise in that, in working with environments to mitigate and to try to prevent the spillover of viruses and other pathogens. At the same time, like bioterrorism, we actually need some of the same systems in place, whether this is naturally occurring, whether it's a lab accident or whether it's a bioterrorist event. And the question in China of whether these viruses, which were of animal origin, were mishandled is an open question. And I expected a question on that. So I'll just say that I'm agnostic. We just don't know yet. But the hypothesis that this could have been mishandled, dealt with in a lab that wasn't properly secured in Wuhan is certainly a hypothesis that needs more investigation, as does how did this move from a bat to humans in China.
Yeah, okay. Let me see. I don't see any more questions. Yes, let's see what we have here. No, I don't think so, but let me just ask one more. There's been some items in the press about the US still having a very stringent limitation on visitors from the European Union. And I was wondering if you could comment whether you believe this is justified, whether it might be reviewed again, because it's not reciprocal, because to go to Europe, you simply need to show proof of vaccination and they let you in.
Well, I'm a personal counterexample to that because I did spend the summer in Sweden as the spouse of a dual citizen. So I was able to come in as a close relative of someone with a Swedish passport who was entitled to go to Sweden living in the US. But Sweden still would not have allowed me just on the basis of my vaccination. Other European countries have taken a different tack. The European Union has come out with guidance, but it's not binding on its member states. And this is one of the ironies of global health, that it has always been a national responsibility, even in the EU discussion of subsidiarity. What does the union have responsibility for and what the individual member states have responsibility for? Health has been the first on the list of national responsibility and even subnational responsibility, as in the US, where states and counties and all this take responsibility. Travel restrictions are covered in something called the International Health Regulations, the only binding WHO international agreement. We have not observed, nor have most countries observed, the guidance that's given for what should be the cause of travel restrictions, how they should be notified, how they should be enforced. We are still not abiding by the best practice in terms of health restrictions. Vaccination should be, from my dilettantish policy point of view, not as a public health technical expert, but I would say that what you've said would be a wise policy for the US, that we probably would be justified and manage the risk appropriately by letting fully vaccinated people in from whatever country. Whether we would allow people with the Russian or Chinese vaccines in is both a scientific and a policy issue. But we're not there yet. And most countries actually, we're not unique in that. I mean, that in terms of restrictions, India is probably causing the most disruption in the world by prohibiting export of any vaccines, being the leading vaccine manufacturer in the world. The AstraZeneca, which is the main vaccine that COVAX has ordered, is not able to be administered outside of India because Serum Institute of India can't export it, even though they have valid contracts to do so, to hundreds of millions of doses to COVAX, and these doses exist. So there are a lot of just incongruities and disruptions that are policy caused and are not being addressed by, I think, the best use of data and evidence to inform policy, where there are real risks, but those risks can be managed if we understand the data better.
Okay, thank you. We do have one question, and I'd like this to be the last question. Okay, and also for those of you who are interested, Frank Young, who is married also to a dual national, about how you get into Canada or what the difficulties are. So I don't believe there's any need for Frank to ask his question, but let's go to Catherine Hill Herndon, who has a question for Ambassador Kolker about the role and performance of WHO during the COVID crisis. Catherine?
Yeah, just quickly, Jimmy, I'd be interested to know what you think about how the WHO has been doing and if they improved their coordination of the regional groupings. And I will mute myself and listen to your answer.
Thanks, Catherine. First, I should give ourselves some credit. I think the reforms that we certainly advocated for and were directly involved in instituting at WHO in 2015 after the Ebola outbreak and their dismal failure really to deal with that properly. Mike talked about the visit from Regional Director Moeti. She replaced the person who was the problem. WHO is dealing with its regional offices and its country representation in a much more professional way now. They have competent people who know what they're doing, who put public health first, who are good communicators and are persuasive people with their host governments in those positions. And so they get credit for that. They also merged their outbreaks and their emergencies teams. It's well led. They had Pete Salama there for a long time. Mike Ryan is doing a good job. They did the right things at first. They were deferential to China. Unquestionably, the WHO should have been more outspoken in challenging some of what China said. But as we both know, that is the way the WHO works. It's a member state organization, and they're deferential even when after we'd withdrawn our membership, they were deferential to the United States in not directly challenging things that we were doing, naming names and shaming. I think they need to get tougher on that. We need to institute reforms which give them a power of inspection without a member state authorization, which give them much more freedom to speak out. But there are limitations of being a member state organization. Their even larger limitation is that they can't deal properly with the private sector. They cannot enter into the kinds of contracts that Warp Speed or COVAX can with manufacturers, which were the key to addressing this, and which we, as the US government did pretty well, which COVAX was probably a good structure to set up, but is now hampered by the fact that it's subject to member state restrictions like India's, and that it doesn't have, it needs funding. CDC's, NIH's budget is 10 times the budget of WHO. And we expect that it has huge unfunded mandates, just an unlimited number of things they could and should be doing. And then they have no surge capacity to address an outbreak. They have to depend on member states to help them surge. And those mechanisms are rusty. They're not well financed. They don't train, they don't exercise. If this is not the way we deal with a crisis, we need to be able, the people shouldn't be introducing themselves for the first time when the crisis breaks out. They should have had an ongoing working relationship. And WHO is is even more guilty of that than the United States is in terms of our own response.
Okay, thank you. Just a couple of comments. The previous director for Africa for WHO became the Minister of Health for Angola. If you know who I'm talking about.
Sure. No, we know him well, and there were some tense phone calls that Catherine and I probably both had with him.
Yeah. Well, anyway, again, I happened to be on another short-term assignment to Luanda when the yellow fever outbreak occurred.
And another
and that's
success.
when he became the Minister of Health. And
But
so
WHO handled that well. That was the first
Yes.
real test after Zika, when the new structure of WHO was in place and they deployed people like you. They did surge and they got it right. And yellow fever could have been a huge outbreak in the rest of the world, and it was restricted to Angola and Congo. And it was a shame there were hundreds of people who were affected, but there weren't tens of thousands of people who were affected, and that made a huge difference.
Yeah, well, again, and also there was a surge from CDC to Luanda, even though the government was overly bureaucratic rather than flexible when it came to visas. But that's another story. Anyway, I was curious, since I also work for the Pan American Health Organization, if their immunization fund was able to be effective for during the COVID period.
You know, it's a great question, and it is an untapped asset. This is one that COVAX did not align itself with that fund. The private sector partners of that fund are reluctant partners because they think they can get more money elsewhere. So they're not eager to replicate that model, but it has been very effective in getting middle income countries access to vaccines, in particular vaccines, at favorable prices by combining their purchasing power. And Mike, you were there and involved in all this, and it's had a number of successes. And it's an underused asset that I think could have been used early on in the COVID response, and still offers a way. How do we get the best lessons of that combined with COVAX, which has to have a much more ambitious clientele and deal with low-income countries, deal with high-income countries as well in a much different kind of emergency market. But it's a great example of one of the things, PAHO, an innovation that worked. And we haven't paid enough attention to that as a success.
Interesting. Okay, well, I think, don't see, no more questions. I think we're good. I'd like to thank all the participants for their curiosity and their participation. And of course, Ambassador Kolker, thank you for an enlightening and interesting presentation and follow-up questions. And we look forward to perhaps inviting you back again at some time in the future to see where things stand, and look forward to staying in touch.
Well, thanks. I'll point over my right shoulder to it. You can barely see it, but the plaque that you gave me as thanks for the talk arrived yesterday. So it
okay,
is
great. Well, it's our
pleasure.
Well merited. All right, Rebecca, Ellen, any further comments? Otherwise, we can close this out.
No, just once again, thank you very much, Ambassador Kolker. I'm sure everyone enjoyed the presentation, and of course, we all learned a lot. So thanks.
Well, thanks. I wish this weren't a topic on everyone's agenda these days, but it's likely to stay with us for a while. So I'm pleased that we had so much expertise from your membership. You have some real health diplomats there, and I hope you'll keep the topic alive.
And hopefully one day when travel is easier and safer, you'll come down to Florida. I understand you have a family connection here.
Right. Almost all winters I've come to Florida except the last two. So
yeah, well, we'll get you back. All right. Thank you very much, everybody. Bye-bye.
Thanks. Bye-bye.